Ramakrishnan. He speaks on sleep disorders in diabetes. I'm really afraid nowadays sleep disorders during nocturnal time, sleep disorders during diurnal time. It will be the issue after a period of time because most of the youngsters, they are resorting to sleep during daytime rather than night time. People are becoming more nocturnal rather than diurnal. So let us see what Dr. Ramakrishnan speaks on sleep disorders in diabetes. Thank you.
Good morning. Thank you for the invitation, and it's a real pleasure to be here. I don't know, part of the slide is not showing up. Okay, I think there's been a tremendous focus on non-communicable diseases, and I think we've been hearing about several of them, obviously, in a diabetic conference. And we know that this is probably causing more fatalities than communicable diseases, about which we're probably going to hear in the next session. But when we talk about the risk factors for non-communicable diseases, we often think about blood pressure, obesity, and several of those, but we forget the sleep disorders, which is probably a significant epidemic that we are beginning to see, and it's probably one of the most important causative factors for non-communicable diseases that's often forgotten. So really the talk is more to create an awareness to wake up on sleep disorders and the links to diabetes. For some reason the slide is not showing up. I don't know what. Is there a problem with the slides? It's not showing up. Okay. I hope it doesn't continue with the other slides. But just wanted to start off with this study that was published in Lancet Diabetes and Endocrinology in January of 2015. Really, the title was Dying for a Good Night's Sleep. And the thought was diabetes may be caused by several modifiable risk factors, and one of the things that they mentioned about was the urban change that is happening right from the noise pollution and other things, and the impact on sleep disorders, which in turn can have a significant effect on diabetes. When we think about sleep, we often think about what is a good quantity or what is the amount of hours of sleep that we need, but it's not just the number of hours that we sleep, it's also the quality of the sleep that really matters. And when you look at this, what we call hypnogram, you can see that approximately once in about 90 minutes, we go through a cycle of REM and non-REM sleep. And the earlier part of our sleep has very little REM sleep, probably just about 5 minutes or so. And as you progress deeper into the sleep and closer to when you wake up, we have much longer periods of REM sleep, and which is probably one of the reasons we remember dreams when we wake up in the morning, because only dreams that happen during REM sleep are remembered, and those that happen during non-REM sleeps are not. I don't think any of the slides are showing up. I don't know why. Okay, what are the common sleep complaints that we often see in the sleep center? Number one, people who don't sleep, those who have insomnia and feel that they don't get enough hours of sleep. The second is those who think they don't have a sleep problem because they are sleeping all the time, sleeping long hours, having daytime sleepiness, as was often mentioned about, and that could be one of the often reported sleep complaints. The third thing is those who go to sleep on time, wake up on time, but have a fragmented sleep pattern whereby they wake up several times. And in diabetics, one of the common conditions that leads to that is restless leg syndrome. And if patients have the fragmented sleep pattern, that also can have an impact on, on sleep. Parasomnias are those where when there is an abnormality that's happening during sleep, like sleepwalking, sleep talking, sleep screaming, talking, any of those. And there are also circadian rhythm disturbances that are often seen, particularly in shift workers, which seem to have an impact on several aspects of metabolic health that we will be thinking about. Okay, so this is a patient, real life, young guy, 45-year-old male who presented to the intensive care unit with a stroke, had right-sided weakness, and his past medical history had the typical risk factors that you would think about: the hypertension, diabetes, coronary artery disease. But introspectively, when further questioning was done, he has been unwell, has had some kind of a sleep problem for a while. He's been snoring, and he also lost his job, got divorced, had depression, all of which could be linked to an underlying sleep disorder that was kind of missed. And he had seen several several consultants, including internists, like cardiologists, emergency medicine physicians, and this was probably missed for quite a while. So what is really the prevalence of obstructive sleep apnea? And in the interest of time, I'm going to focus more on obstructive sleep apnea and diabetes and not all the other medical issues that we are going to talk about. Overall, several studies have looked in several countries, and you can see that there is a significant prevalence of obstructive sleep apnea in patients with diabetes, and as you can see, mild, moderate, severe, all of which are more common, and probably more of the moderate and severe. So this confirms, several studies that are listed. As you can see, the odds ratio of diabetes was significantly increased as patients had moderate to severe obstructive sleep apnea. This is one of our own studies in collaboration with the MV Institute or MV Hospital for Diabetes, where we found that if patients had uncontrolled diabetes, those patients who had HbA1c more than 7, when we looked at them, and particularly if they had some coexisting symptoms, particularly snoring or daytime fatigue and sleepiness, we found that there was a high prevalence of diabetes in them. Almost 23% of these patients had significant obstructive sleep apnea, and this was published in JAPI, where the editors commented that majority of patients with diabetes, particularly uncontrolled, seem to have coexisting obstructive sleep apnea. Another study published with the same group. The reason I'm even bringing this up is when we think about patients with obstructive sleep apnea, we imagine somebody who is obese, we think of the typical Pickwickian syndrome, but honestly in India we seem to encounter a lot of patients who are non-obese but have obstructive sleep apnea, and that may be related to our craniofacial structure or central obesity. We really don't know, but we found that at much lower BMI values, these patients seem to have significant obstructive sleep apnea. So what really do these patients have? What do they present with? As was mentioned, they may have nighttime symptoms, which are often noted by others, which is snoring, witnessed episodes of apnea or choking, patients complaining that they have significant nocturia, which they may often attribute to their diabetes, but it could also be due to the coexisting obstructive sleep apnea, dryness of throat. These are overall having a restless sleep is what they complain in the night time, but they could also have significant daytime symptoms, which include waking up not feeling fresh, waking up with headache, feeling tired, sleepy, particularly when you are not focusing, but it could get to a point where they could be unable to concentrate and have sleepiness even when they have to focus, particularly when they are driving or at work. How do we diagnose? These patients undergo a sleep study, and one thing that we look, and this is not the only thing that we look, is what we call apnea hypopnea index, where we look at the number of apneas which is witnessed, episodes where they are actually stopping breathing for more than 10 seconds or slowing down breathing, which we call hypopneas, and we average for an hour. And when the apnea hypopnea index is less than 5, we call it normal. If it is 5 to 15, we call it mild obstructive sleep apnea. 15 to 30 is moderate, and when it is more than 30, it is severe obstructive sleep apnea. There are different types of sleep studies, which I'm not going into, but when you have a high clinical index of suspicion of moderate or severe obstructive sleep apnea, we often do a portable sleep study in India, but the typical gold standard is a polysomnogram that should be attended and done in the sleep lab, which we reserve for patients who may have other coexisting disorder. I think several have mentioned about inflammatory state, not only diabetes, but several other conditions that could increase the inflammatory state in our system, and one of those is obstructive sleep apnea. And it has clearly been shown that it is not just because of the obesity, but sleep apnea can be an independent risk factor for diabetes, hypertension, and coronary artery disease, as I said, unrelated to coexisting obesity. What exactly happens? What could be the reason why they develop it? Again, not to go into details, but patients with obstructive sleep apnea can have a pro-inflammatory state oxidative stress, there is increased sympathetic neural activity, and therefore they may not have what we call the traditional nocturnal dip in their blood pressure, all of which seems to predispose them to coronary artery disease, diabetes, and increased diabetic vascular complications, including diabetic retinopathy, diabetic nephropathy, cardiomyopathy, and any of those. Okay. So, what happens to metabolic regulation or dysregulation, if I may say, in patients with obstructive sleep apnea? They are known to have reduced glucose tolerance, reduced insulin release. They could have increased leptin, ghrelin, hunger and appetite, and therefore patients with obstructive sleep apnea are prone to becoming obese if left untreated. And that's why there's a lot of focus on lack of sleep or inadequate sleep, fragmented sleep, all leading to obesity in our patient population. There is clearly a link with insulin resistance, and therefore we see more of the type 2 diabetes patients with obstructive sleep apnea, as we were talking about. Now, in the next few slides, all I just want to say is prove a point, saying that if you have obstructive sleep apnea and you remain untreated, it has been shown when in follow-up studies that these patients can develop diabetes mellitus. So these are patients who did not have pre-existing diabetes, had obstructive sleep apnea untreated, and when they were followed, clearly had a higher incidence of diabetes, as was shown in this study. Next, those who already have diabetes, if they have obstructive sleep apnea, it can have an impact on the glycemic control. And I mentioned this earlier in our own study where we looked at prevalence, but it was shown that 77% of the diabetics had obstructive sleep apnea, and here they classified anybody greater than AHI of more than 5, which is mild obstructive sleep apnea. And it was also shown that as the severity of the obstructive sleep apnea increased, the glycemic control was also getting worse. Several studies have shown that. I just will show that in the graph here again in the interest of time, where they found that the adjusted mean values of hemoglobin A1C was much higher when you had a more severe form of obstructive sleep apnea, and particularly when it is remaining untreated. Now the next question is, we say that if you have obstructive sleep apnea, you are at increased risk of diabetes. If you already have diabetes and have obstructive sleep apnea, which is untreated, then you have a higher chance of your diabetes not being controlled. Now the logical next question is, what if you treat these patients with obstructive sleep apnea? Would it help control of their blood sugar or the glycemic control? And there have been studies done with CPAP treatment of patients with diabetes and high HbA1c level, where they found that as you start treating them, definitely their glycemic control is better. And they've looked at postprandial blood sugars, and it was shown to be improved in those who are treated with CPAP compared to those who remain untreated. And really, it increases the insulin sensitivity, but more importantly, how soon can you really start seeing this effect once you start treating a patient with CPAP? And again, this is the same study that I was mentioning earlier. In groups where HbA1c was more than 7, after the CPAP, they found that the HbA1c was significantly improved, and the effect was seen as early as in a couple of days. Not the HbA1c obviously, but the blood sugar control was better in 2 days, but the sustained effect was seen after about 3 months, which is right about the time you would probably recheck your HbA1c. So if you start treating the patient with obstructive sleep apnea, if they are on supplementary insulin, it would be a good idea to follow in the first few days much closer, as you may have to start adjusting the dose early. But when you will start seeing a more sustained effect is in about 3 months, and that's when you probably would be rechecking your HbA1c level as well. But again, like in anything else, not all news is good news. There have been studies that have looked at CPAP treatment and said that they didn't find sustained effect in patients with diabetes, and some of these studies included patients with type 1 diabetes as well. So there may be a I shouldn't say inappropriate group, but the fact that all patients were clubbed together may have influenced some of the reports, because we find that the effect is more sustained in patients with insulin resistance and particularly those with type 2 diabetes. What about sleep apnea and diabetic complications? As I said, the pro-inflammatory state, the intermittent hypoxemia, the free radicals that are generated, all of these seem to increase the vascular complications, and there seems to be a phenomenon of what we call accelerated atherosclerosis that happens in these patients. There have been studies looking at carotid Dopplers on patients with obstructive sleep apnea, and it's been shown that these patients can progress with atherosclerosis much more rapid. So both macrovascular and microvascular complications have been shown to be more in diabetic patients with several of the studies that I'm pointing out here. So there was higher incidence of retinopathy, higher incidence of neuropathy, and higher incidence of diabetic nephropathy in patients with coexisting obstructive sleep apnea. Well, I just wanted to close with the last couple of slides, and I just wanted to present one of our own studies where we looked at 1,000 consecutive patients in our clinic and wanted to check how many of these patients were referred by other specialists and how many of them presented by themselves, looking at media and other. So here we found that more patients, almost 60% of them, actually presented themselves, and only 40% of the patients were referred by other consultants, which made us wonder, in sleep medicine in India, are patients getting more aware through media rather than getting referrals from other consultants. There was slightly higher referrals with obstructive sleep apnea compared to other sleep disorders, particularly insomnias, parasomnias, restless leg, and several of the others. So I wanted to conclude by mentioning that sleep disorders are common in general and extremely common in diabetic patients as well. Often go unrecognized, and treating them with medication may not always be the answer. In fact, if they have sleep apnea and complaining of non-refreshing sleep and get treated with sedatives, it's actually going to make them worse. So it is important to recognize the problem early and start treating them. There is a bidirectional relationship. One of the risk factors for obstructive sleep apnea is diabetes, and one of the risk factors for diabetes and uncontrolled diabetes seems to be obstructive sleep apnea. And the relationship is not just related to common factors like obesity or hypertension, is what I wanted to highlight. And there seems to be an effect on treatment. When you treat these patients with obstructive sleep apnea with CPAP, it seems to impact their glucose metabolism and control their blood sugar better. So I just wanted to close and invite you all for next year's SleepCon, which is going to happen in Chennai in April 10 to 12. Thank you.